Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Kimberly Miller. In today's episode, we will discuss barriers to RSV vaccination for adults, including insurance coverage and vaccine hesitancy, and explore effective, practical strategies for overcoming these barriers. I'm joined by Dr. Laura P. Hurley, Associate Professor of Medicine in the Division of General Internal Medicine at the University of Colorado, and Dr. Carolyn Bridges, Consulting Physician and Director of Adult Immunizations at immunize.org in St. Paul, Minnesota. This episode is part of a larger educational program titled Removing Roadblocks, Practical Approaches to Increase Adult RSV Vaccine Uptake. For more information on Drs. Hurley and Bridges, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started with Dr. Hurley.
I want to start with people being complacent about thinking they need the RSV vaccine. And I think that stems from RSV notably being something we think about for pediatric patients, but we don't think about it much for adults because it doesn't present distinctly. When somebody comes to you with a cold, you can't say, oh, it's RSV. It could be a lot of other respiratory viruses. And I think we also underappreciate how much the RSV virus can contribute to other conditions, CHF exacerbations, COPD exacerbations. And so we really need to bring that up with patients when discussing RSV vaccination. So I want to talk about the importance of age and increasing the susceptibility and mortality to RSV-associated pneumonia. But before I do that, I want to point out that there was a study published in 2015 looking at causes of a community-acquired pneumonia, trying to get a grasp at what are the big offenders in terms of that disease. And it was found that RSV was the fifth most common reason for community-acquired pneumonia in this population-based study. In that particular study, they evaluated RSV-associated community-acquired pneumonia and found that rates were a lot higher in the older population, so people less than 80, as opposed to the 50 to 64-year-olds and 65 to 79-year-olds. There's been other publications pointing out the importance of RSV requiring hospitalization. And in one particular study from France, the mortality was noted to be about 6% in hospital from RSV-related disease. Another population-based study that was conducted in Southern California looking at the epidemiology of RSV found that RSV-related hospitalizations are associated with a lot of morbidity, including 30% of that population having bacteremia and sepsis associated with RSV, and 21% requiring ventilation for their RSV-related disease. And you see that mortality is quite a bit higher in that 75-plus group compared to the younger age group, just emphasizing the importance of age being a risk factor for RSV disease. Hospitalization rates are much higher in 65 and older for SARS-CoV-2, influenza, and RSV. There's also disparities in terms of hospitalizations related to RSV disease, with American Indian, Alaska Natives having the highest rates of hospitalization related to this, far higher than non-Hispanic whites, and it's the lowest in Asian and Pacific Islanders. Just things to keep in mind when you're discussing RSV vaccine with a particular patient. I think there's a lot of misinformation about vaccines out there, and you might be faced with a patient saying, well, I don't think it works, so I don't want to experience potential side effects from something that's not going to help me. So how could you possibly address that? These population surveillance studies are evaluating outcomes that we care more about, so hospitalizations. And there's a series of different networks that are constantly surveying vaccine effectiveness. And you can see from that information, it showed that the vaccine was anywhere from 72 to 83% effective in this first season where a vaccine was available. And notably, these surveillance studies evaluated individuals who were 75 and older, and also in some instances were immunocompromised. So potentially people that were trying to protect even more. So far, we don't have information about the mRNA RSV vaccine, but that should be forthcoming. So what about concerns about the vaccine harming a patient and that being a barrier to having a patient accept RSV vaccine? This is information from the package inserts for the 3 vaccines. You always have to be concerned about anaphylaxis with any product we give a patient, a vaccine or a medication, and be prepared to address that if needed. I think in terms of a history of severe allergic reaction to any vaccine component, I think it's kind of hard with these vaccines to identify exactly what are the vaccine components to be able to tell a patient that it should be avoided. So that's a little bit of a gray area. But always with a vaccine, you should tell patients that there are going to be local reactions, myalgias, headaches potentially, and those are to be expected, and they are short-lived and hopefully will protect you during the winter season and have you be able to do the activities that you want to do. So there are concerns about Guillain-Barré syndrome, and I think you should bring that up with patients, but we're going to talk about tools to address that fear. Background rates of GBS in the US from 2 different study groups point out that in the older populations, GBS is more common. So we need to understand that going into a discussion of GBS with patients that are considering the RSV vaccination. I also think it's important to highlight for patients that might have already received a flu vaccine that flu vaccine is also associated with GBS, with possibly an additional 1 to 2 cases of GBS per million doses of vaccine. So it's not common, but it happens. And perhaps your patient has also received recombinant zoster vaccine, also associated with GBS, with about 3 excess cases per million doses of vaccine delivered. So this is a side effect not unique to RSV, certainly a terrible side effect that we don't want to happen, but it needs to be put in context when discussing this vaccine with patients. It seems that the benefits of these vaccines are outweighing the risk of a patient developing GBS post-vaccination. So often for our adult patients will say, well, I don't know if I can afford to get it, so I don't want to get it. Let's talk a little further about that. So for most plans, this vaccine, by virtue of it being ACIP recommended, is covered by private insurance, Medicare, and Medicaid with no out-of-pocket patient costs. For those Medicare beneficiaries, the vaccine is covered by Medicare Part D, which is internists. We all know that that is a pharmaceutical benefit, which can create barriers to administering it in the office. For example, I can't administer RSV vaccine in the office, but I work in an integrated health system and I send those patients to a pharmacy to get the vaccine. I imagine some of you are doing that. When you're doing that, not necessarily in my integrated system, but if you're sending a patient out to a retail pharmacy, if they're in that younger age group, the 60 to 74, it's a good idea to list a risk factor as the indication, just in case there's any issues with the payer not wanting to pay for it because they're not considering the patient a high-risk group. There's also an opportunity to bill from your practice administration using a system called Transact RX. Historically, I haven't seen that that's used a lot, but that it is possible to administer the RSV vaccine in your practice. And we always recommend, because we're sending some patients out of the clinic to receive the vaccine, to make sure you have a way to document any vaccines that were received outside of your system, like being able to tap into the immunization information system in your area. What if patients say, I don't have time to get vaccines? We've been talking about my diabetes, heart failure. You're saying I need to get 3 vaccines today. I don't want to do that. What might that conversation look like? So one way to avoid being too time consuming is to co-administer, if there's another vaccine in addition to RSV, to go ahead and co-administer multiple vaccines at once. That is the party line from the CDC, that you can give RSV vaccine with other vaccines. Admittedly, there is limited data about administering RSV vaccine with other vaccines, but there is some data. For RSV pre-F, there is data that co-administering, at least with the adjuvanted inactivated flu vaccine, that it's safe and tolerable and there's non-inferior immune responses. For the RSV pre-F3 and the shingles vaccine or the recombinant zoster vaccine, so both of those vaccines use the same adjuvant, the AS01E, there is evidence that that is safe and doesn't produce an inferior immune response if you administer those together. And lastly, the mRNA vaccine, studies have been done to look at that being co-administered with the mRNA COVID and flu vaccines, and it appears to be safe with non-inferior immune responses in that situation. However, what if a patient says, I don't want to get them all at once? I'm not that worried about time, actually. You don't have to wait any particular interval between inactivated vaccines like the RSV vaccine. So if they want to say, I want to come back in a week, that would be fine. And this is a situation where you can come to an agreement with your patient. I have lots of people, I think by virtue of the COVID pandemic and COVID vaccines being very fearful, we were offering people days off when they got their COVID vaccine. And I often talk about the recombinant zoster vaccine has almost equal side effects to COVID vaccine. So I think it's a situation where if they're very concerned about vaccines historically from what they experienced during the pandemic, and you think they're reliable to return to have a vaccine, it's okay to have them wait if they're a working person until a Friday to get their vaccine, and so they can recoup over the weekend. So I want to just take a few moments to talk about vaccine delivery infrastructure, because I think when people ask me about how I get someone to receive a vaccine, they go straight to, well, you should do motivational interviewing. And as an internist at an FQHC, I'm like, I have less than 30 seconds to talk to a patient about a vaccine. So I like to spend some time with internists like you talking about infrastructure. Let's set ourselves up for success, okay? And that harkens me back to an old publication, 11 years old, from the National Vaccine Advisory Committee that talks about standards for adult immunization. One thing is to assess vaccination status at every visit. How do you do that? I, as the physician, am not necessarily going to remember at every visit, but the majority of us are using electronic health records, which can help us prompt ourselves to bring it up. And not necessarily us, but whoever administers the vaccine in our practice. In my particular practice, it's the medical assistants. All of you should know that physician recommendation is critical for vaccine acceptance. And so you should, if it hasn't already been given before you go in the room, you should say, you should get this vaccine. And that has been shown to be very effective in encouraging patients to receive a vaccine. And then I think we need to be set up with what our strategy is, given that for some of our patients, we're not going to be able to administer in the practice. We're going to have to refer out, and you need to know how to direct a patient to go get a vaccine outside of your clinic. And then lastly, I really encourage all of you, if you're not already, to have bidirectional communication with immunization information systems, because patients will get a vaccine potentially while they're getting their groceries, and you want to be able to see receipt of that vaccine so it can be documented in your record and you don't have a best practice advisory firing every time the patient comes into clinic. And then I think another thing to consider is the very complex nature of vaccine hesitancy. It's not all about scared about getting a shot. It's about whether it's going to work, whether the person that's giving it to them is competent to give the vaccine. It's about complacency, people not necessarily thinking they need the vaccine. And that's why we were trying to drill home the point to understand the morbidity and mortality of RSV disease in these older populations. We, as physicians and APPs, we need to be addressing the misinformation that is so prevalent about vaccinations in social media and other venues, particularly important at this time. And we need to face that, having patients leave the practice to get a vaccine is a barrier, and try to have systems in place to make getting vaccines as easy as possible. And also understand the context. You probably, like me, see patients from very different cultures and life experiences. and being able to meet them where they are with how they feel about vaccinations can be important to convincing a patient to receive a vaccine. And if you have time, and I would venture to say in a lot of our practices we don't, motivational interviewing has been shown to be successful at improving vaccinations, particularly in pediatric populations. So we're going to talk about obstacles that you all have experienced further. So one that we did not discuss, lack of resources and lack of availability.
So I'm not aware of any supply issues. One thing that can be challenging is when any new vaccine is recommended on the market, sometimes there can be delays in terms of payment from payers. So that's just one thing to be aware of. Once a new vaccine is recommended by ACIP, payers have a year to officially to cover that vaccine. Most of the payers will be able to start paying that sooner, but because you and the patient don't want to get stuck with the bill not paid or denied claim, sometimes it's really helpful to check with your payers first to make sure that they are currently covering that vaccine and they're not delayed in starting to cover that.
Yeah. So another question is this a one-time vaccine? And yes, currently this is a one-time vaccine, but I think you know that ACIP, at least historically, has met several times a year and are open to updating vaccine recommendations based on evidence. And so the information I was presenting was for the first 2 years of the vaccine being available. We know that the effectiveness declines. And so it could be that we start recommending future doses of the RSV vaccine, but currently that isn't the recommendation. So currently it's a one-time dose.
So one question also that we received is obstructive sleep apnea considered a risk factor? So regarding obstructive sleep apnea, it is currently not included on the CDC recommendations, although if someone had obstructive sleep apnea and had complications from that, congestive heart failure or other issues, then of course, if they had another indication, that would be a risk factor. But obstructive sleep apnea alone, I currently don't see that is recommended.
There's a question related to the efficacy of the 3 vaccines, whether one is kind of shining above the others in terms of efficacy.
There is no preferential recommendation for any of the 3. And if you look at their clinical trial data, their effectiveness estimates, really the confidence intervals overlap substantially. So it looked to be very comparable. So one question asked in my dialysis unit, if patients asked if they want a vaccine, 60% get it. If the nurse says it's the vaccine your doctor ordered, we get close to 100%. Since the pandemic, I can't get more than 75 to 80% anyhow. So I do think this brings up a really important point that the whole care team needs to be coordinated. If someone talks to one person on the care team and they are less enthusiastic or sure of themselves about a recommendation, that really can have some negative cascading effects. I do think that all of us have experienced more challenges with vaccine recommendations today, and it does take time. So it's definitely a commitment. Using standing orders can help. Making presumptive recommendations. So saying, Mr. Jones, today you're due for RSV vaccine and flu vaccine. That can help rather than saying, boy, you really don't want these vaccines today, do you? Or leaving it more open. Or what do you think about getting your pneumococcal vaccine today? Really being very clear with, you have chronic disease X, Y, or Z. It's really important that you are up to date on your immunizations, and this is what I recommend for you. So that definitely helps, and that real consistency on the part of the care team. And then sometimes it can take a few conversations. That's where the standards come in. They really recommend bringing up needed vaccines at every clinical encounter, realizing that sometimes that can't be done given busy clinical schedules, but sometimes it takes a few conversations. And then lastly, patients want to know why me personally. So however you can personalize that information that makes it clear why that individual, why it's important for them, for their situation, for their age group, for their risk factors, that can really be helpful.
I want to address this question. It says, if they receive the vaccine before 50 years old due to other risk factors, would they need a booster in the future? And I just want to say, currently, there's no recommendation for anybody less than 60 to receive the vaccine, even if they have the risk factor, even though FDA has approved one of the RSV vaccines in that younger age group. And so I just want to be real clear that the recommendations start at age 60 currently, and that there's a difference between FDA approval of a vaccine in a certain age group and what ACIP ends up recommending based on their grade approach to recommending vaccinations.
So someone asked whether autoimmune disease were considered risk factors. That may depend on the severity of their immune compromise. So moderate to severe immune compromised persons, those people are recommended for RSV vaccine if you're 60 and older. So not every autoimmune condition, but those who are moderately or severely immune compromised.
Why do you think there's no GBS seen with mRNA vaccine?
So both for the RSV pre-F and pre-F3 vaccines, there were some cases of GBS, few, I think total of 3 between the two phase 2-3 clinical trials for those 2 vaccines. And so additional investigation was done post-licensure. So for the mRNA vaccine clinical trials, there were no cases of GBS, but as we've seen, GBS is a rare complication for the other 2 RSV vaccines. So these clinical trials have around tens of thousands of patients, but the risk of GBS is around a few per million doses administered. So it's because of these rare adverse events that can occur with any medication or vaccine. That's why they do the post-licensure safety monitoring to see if there is a severe risk factor that may come up post-licensure once you start vaccinating a lot of people. So I don't think we can say yet that there is no risk of GBS after mRNA vaccine, but we'll continue to follow the safety data as it's monitored post-licensure for all of these vaccines.
I think in summary, so we know with the adjuvanted and the pre-F vaccine that there were a few cases that weren't shown with the mRNA, but we don't have that observational data for the mRNA RSV vaccine.
Would you recommend RNA vaccine for someone with atrial fibrillation? That is not specifically called out as a risk factor. If you're wondering about the cases of AFib that were noted during the clinical trials for the pre-F vaccine and the adjuvanted vaccine, they did see some numerical differences in AFib, but then in the post-licensure studies for safety, they did not find an increased risk of AFib with those 2 conjugate vaccines. So there is no risk of AFib that we have identified in post-licensure studies, and that also has not come up as an issue with the mRNA vaccine. So AFib is not a contraindication for any of these vaccines.
There's a question about preferring one RSV vaccine over another for somebody who's potentially highly immunocompromised. And really, there is no preferential recommendation for one vaccine over another. I have to say, in my clinical experience, I only have one RSV vaccine available at my integrated pharmacies. And I am not sure that if you go to a retail pharmacy, you're going to have a choice of which RSV vaccine you're going to receive. You're going to get whatever they're stocking at the retail pharmacy, I would imagine.
I'd imagine similar to, for example, COVID-19 vaccines, one could make a request, but that doesn't necessarily mean that every location is going to carry every different brand.
In summary, we have 2 recombinant RSV vaccines and 1 mRNA vaccine that have all been FDA approved for individuals 60 and older. In adults age 60 and older without immunocompromised conditions from another sort of population-based surveillance study conducted in the U.S., RSV vaccines, it's a combination of the 2, have showed 80% efficacy at preventing hospitalizations and 81% efficacy against ICU admissions, death, or both. And currently, ACIP recommends a single dose of RSV vaccine for all adults 75 and older, or adults 60 to 74 at high risk for severe RSV disease.
Thank you, Drs. Hurley and Bridges, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Removing Roadblocks, Practical Approaches to Increase Adult RSV Vaccine Uptake, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.